Dr. Jyoti Matalia, and she is going to speak to us on spectacles. How can they prevent myopia progression? Dr. Jyoti.
Should I go there? Thank you so much, AIOC and Dr. Nahane and everyone here. I'm going to be talking on importance and optical therapy. So let's look at this particular chart. It talks about the global prevalence of myopia and high myopia and the temporal trends from 2000 to 2050. And you can see the initial figures are about when it was. So in this you can see the East Asians had the maximum, and we know that the Chinese population had more myopia than unlike the others. But as you see, the trend is moving on, and eventually we were going to have 50% of the population becoming myopic, which means 1 out of every 2 person is going to get myopic, of which 10% are going to have high myopia. So this is a very, very serious issue, and as we came out of a COVID pandemic, we are surely going into a myopic pandemic. Hence, it's important, and that's why everybody's talking about the various myopia control. But as I said, most importantly, what we have to look at is a lifestyle modification. Whatever we treat, we have to keep on telling the patients, reinforcing every visit, the lifestyle, which is very, very important, because that has completely changed to what was about 20 years ago. So with this, I'm Dr. Jyoti Matalia, and I'm going to be talking to you on the optical therapy in myopia. So what are the various theories of myopia progression? Yes, the feedback which causes emetropization, because of which the eyeball may grow, the dopamine and the scleral biomechanics, the accommodation lag theory, and most importantly, the peripheral refraction. So this is what is about the peripheral refraction. So when you see, normally when you wear glasses, the center part is focused on the retina. But if you can see peripherally, this gets focused behind the retina, that is a hyperopic defocus. And with that came the concept of the defocus devices, where the peripheral part gets focused on the retina, and hence the eyeball will not grow. So what it brings us to our understanding that what are the various options. So one, we have the glasses, that is the peripheral defocus glasses, and the other are the contact lenses, which are there. So what are the, therefore, let me summarize the treatment options, the glasses and the contact lenses. In glasses comes a single vision with undercorrection, the progression addition adds, and the defocus or contrast alternating. In terms of contact lenses, we have the rigid contact lenses or the orthokeratology, the soft bifocals or the multifocals. Now we are very clear that the single vision glasses with undercorrection or progressive addition lenses is no longer used. They do not help. In fact, they can cause progression. That leaves out with the other ones. And now I will take you to each of these individual aspects of spectacle options. There's a very good article which is by the myopia profile, which you can go through, which tells you in details how they work. So first we have the defocus incorporated multiple segments or DIMS by Hoya. We have the highly aspheric lenslets, that is the Halt technique that is the Stellest glasses by Essilor. We have the diffusion optics technology DOT by Essilor, and the cylindrical annular refractive element CARE by Zeiss. So let me explain each of them. The first comes the defocus incorporated multiple segments DIMS by Hoya. So you can see the central zone is 9 millimeter in diameter, and that is for the distance refractive correction. The child will see perfectly through that. Around that, you can see like a honeycomb appearance of 400 multiple defocus segments. These are 33 millimeters in diameter surrounding the central zone. And if you take the magnification of each of this, you will notice that one of them is 1.03 millimeters in diameter, and they are 3.5 diopter myopic defocus. So this together will prevent the myopia, the hyperopic defocus, cancel it out, and you get a myopic defocus. This is how the DIMS works. Then the highly aspheric lenslets or Halt, wherein you can see that they have 11 rings, as you can see. Each ring is actually one lenslet, and together this causes a hyperopic defocus volume, and this prevents the myopia, induces the myopic defocus and helps the progression from happening. Then comes the diffusion optics technology. Now we are aware that there's abnormal interaction between any two cones causes the myopia to elongate by causing axial elongation. So what this actually does, is it induces, causes an alteration between these particular dots and induces an increased glare, and that is the technology, which is a diffusion optics technology, which is introduced by Essilor, and that can also prevent the myopia from progressing. And finally, the cylindrical annular refractive element CARE by Zeiss, where you can see these multiple cylinders. These cause high order aberrations, and they induce the myopic defocus. So you have segments of normal zone and myopic defocus zones together in form of rings which go from center to the periphery. These are put on the front surface, and this is the concept with which the myopia progression can be prevented by cancelling the hyperopic defocus and inducing the myopic defocus. Thus, we have these 4 spectacle options, of which the defocus glasses are there in the DIMS, the HALT by an Essilor, that is the Stellest, and the CARE. Whereas the alteration of the contrast is done by the DOT technology. Now we'll come a little bit quick on the terms that we are aware that whatever DIMS or HALS has been done in Chinese population has shown that it can slow up progression to about 60 to 70%, still not available, but recently we have started collecting data. It's a multi-centric trial which is done all over, initiated by AIMS, where we are getting the data from all the people who are using these defocus glasses by Stellest, and we'll soon be able to give you the data of how the Indian population is doing. A quick thing on the contact lens, because we have Dr. Meena talking, but that when you're looking at contact lenses, we are talking at 2 options. One is the night wear contact lenses, which alters the shape when the patient sleeps with the contact lenses, and best suited for those who don't want to wear anything in the morning. So the advantage is they sleep with the contact lens, but morning they're off any refractive correction, whether it's glasses, contact lens, or anything. And then the other one is a soft CL, again the same concept of cancelling the hyperopic defocus. These are the daytime wear contact lenses. Now looking at the specification, we should be aware that we cannot give it to all. There's a limit to the power that you can give. So it is seen that up to DIMS and ortho-K, minus 10 diopter of spherical refraction equivalent can be given, and maximum minus 4, but Stellest has come with minus 12, which is the overall one which we can consider for those with slightly higher myopia. So optical correction, therefore, to induce myopic defocus are the DIMS, HALT, CARE, ortho-K, and the soft lenses. Now, since we have multiple treatments, our long-term studies in India are still awaited, and we are short to probably for the next AIS one in Delhi, we'll be able to give you our data of how the Stellest is doing. But one thing which I want to know is how do you prescribe? Now, incidentally, we have done a study where we had 228 eyes, and we studied how these patients with myopic progression do. And we were able to show that in spite, we believe that is the peripheral hyperopic defocus that causes myopic progression, but we were able to show that about 54% had myopic defocus, unlike 46, since that means in spite of them progressing, they are still having myopic defocus. And in that, what we noticed is that we had more of nasal progression of myopic defocus, and hyperopic was more temporally. This is just a data to show. So what we do is normally, if we have a myopic or we have a patient who's progressing, we do the peripheral refraction, and we are able to show. So if it's a myopic defocus, we know that in those cases, the glasses may not really do well. So we started them on LGA. So this is our data where we had patients with 122 having myopic defocus. We gave them glasses, with LGA, and some who insisted on glasses were given as well. In those we had hyperopic defocus, we give the option of defocus glasses to them because we know that it'll work better. And in this is the data, what we have done. So basically what we do is, depending on what we have, if we show there's a hyperopic defocus, yes, we go for this option. And remember, you don't need to have a very high instrument like what we had. Any patient who has a retinoscopy, make him fixate at a distance target, give him multiple targets so that he looks at the side and you're able to pick up your peripheral defocus or not. So this is how you can calculate if you are able to show yes. Otherwise, you definitely have, but when you are able to show that he is progressing for more than 0.5, please give him a treatment option. Definitely watch him every 6 months for his axial length and his refraction, and don't forget to tell him about the lifestyle modifications. That is important. And I just want to add that SPOCI and NTOD have got this option of the National Myopia Week, where they want to increase the awareness between 14th to 20th. And therefore, anybody who wants to become part, because we need to spread this word, we don't want myopia, we want to stop it from progressing, is where you can officially send your data and get the details. So thank you very much for your patient listening, and I can take questions now.
From the audience, please.
Shell.
Excellent talk. I just had one question that we've heard about peripheral refraction. So do you recommend it in the undilated state, or would you have?
Yes.
Do you then compare the central peripheral refraction also after cycloplegia and then take a decision, or it's only based on the undilated?
No, it's absolutely based on undilated, because when you do dilated, sometimes your optometrist may not be able to figure out, because your pupil gets completely dilated. ideally is to be done in undilated state, and anything more than 0.75, which is from your center, is what we would consider as a hyperopic defocus, and then look at it as in terms of progression. Also, when we're talking of this is what the patient has. But sometimes when you're giving high myopic glasses, the glasses per se induce a hyperopic this defocus. So in those cases, anything more than 3.54, I also do the peripheral refraction with the glass on and try to see if it is there. So in this case, even if the patient does not have a hyperopic defocus, but I know his spectacles will induce it, I can give them as this option as well.
And would you also try and study the accommodation lag?
Yes.
Because I've listened to lectures where they say that based on that you decide whether you give this kind of classes or if there's an accommodation lag, progressives, or there may be a better option.
Yeah, so what I'm talking about patients who are perfectly fine. So when there is an accommodative lag, then the treatment will not be giving this. You would trackle it, you treat the accommodation issues, and then as a subsequent. So these are patients who are otherwise normal in terms of their orthoptic evaluation.
See, accommodation problems with accommodation lag is a different thing. You know, in children, do you think there is an accommodative anomalies? There are 4 types of accommodative anomalies in children. In my book, I have said that, you know, so accommodation lag and defocus, accommodation infacility, you know, that's a different treatment. There's nothing to do with this. And the one thing, the problem with these disc lenses, that is the defocus lenses, is that the cost. It is about 15 to 16,000 rupees, and it has to change every year. That is one big problem when you prescribe these lenses. Contact lenses are even more costlier. So that cost factor has to be still. Suma, you must be also knowing about that. The cost factor is a big problem. Yes, sir.
Yes, Malik sir.
Would there be time that all refractive surgeons would throw away their glasses and have the eyes like me, which is 6 by 5 and 5?
And last we have Dr.
Any-
Meena Kharat.
Any